Hey everybody, we're back with another episode of Earnest Medicine. We have an exciting guest in today, somebody we've been trying to wrangle for a little while. Dr. Jim Taylor over at Howard University and Dr. Brown's alma mater. So we'll jump in here and kind of get this conversation started with a bit of an introduction and dive in on sickle cell research and control. So I'll turn it over to Dr. Jim Taylor.
Well, thank you for having me. It's a pleasure to be
Absolutely,
here.
and trying to wrangle it, and it's busy schedules. It's always hard.
Sickle cell is an underserved area, so finding the time to do anything non-patient care is sometimes challenging.
Absolutely.
And that's a challenge for any of the clinicians that we try to bring on the show, too, because they're busy, and to be good at what you do, you're hyper-focused.
You got to see lots of patients.
Yeah, and so time is a luxury for sure. Yeah. So thank you for coming. Greatly appreciate it. So we actually met, because we have a mutual patient, which but I serve a population with the developmental disabilities, and we had kind of got joined at the hip because of what I had been seeing on my end and yours. But I think it's always useful to understand, how did some viewers know how I got to where I am, but give us a little background.
Mine is a twisted story.
Good.
So first point is, I'm an adult dyslexic. I got into medical school by the skin of my teeth. It was discovered during college. I was the first learning disabled student at Creighton University in Nebraska. The Jesuits were really challenged by somebody with a learning disability who needed reasonable accommodations. They just don't understand it. Yeah. But they were very accommodating. My grades went up from off to on in the last 2 years of college, and I really got in by the skin of my teeth. I went to the Medical College of Wisconsin in Milwaukee, so former Marquette University School of Medicine, so continuing with that Jesuit mission. And I studied hard and I did well, and I did an honors research project in a virology lab, and my first rotation was in pediatric hematology oncology. And I was like, I knew nothing about this. This is so cool. And I'd been studying the retinoblastoma protein in the lab, and here I am seeing retinoblastoma patients in the clinic. I was like, that's what I want to do. So I went ahead and did a fourth-year rotation. And then I went off to residency in St. Louis at St. Louis Children's Hospital and Washington University. There's a great ER physician there who was studying malnutrition in Malawi in East Africa.
Oh, wow.
And he had heard through the grapevine that I like to adventure travel, and he said, hey, you want to go to Africa? I'm like, yeah. And I spent 3.5 months there working as a registrar and pretty senior level. And you just see everything there. Malaria,
you learn quick.
Cobra bites, malnutrition, HIV was... seroprevalence was 30%.
Jeez.
It was devastating. And it was really hard to compare this to the United States, where you just see children die every single day. But the one thing that I was more experienced at that point was sickle cell disease, because in St. Louis, Missouri, you see a reasonable number of sickle cell patients. I was a third-year resident at that point. So I had more experience than anybody there. A child came in with sickle cell who was comatose. And they called me, and he said, what do we do for him? And as an American third-year resident, you're never put in that position like, you make the decisions about what to do. And I was also fascinated with cerebral malaria, which is where parasitized red cells sequester in the brain, and it looks like a stroke in sickle cell. And so I really started thinking about red cells sequestering in the brain and about sticky red cells, whether they're sickle cells or parasitized red cells. And so then I got into the fellowship at Johns Hopkins and NIH, and my first lab assignment was in NIAID studying hemoglobin C and malaria and its factor as a resistance factor. So I was off to Africa again, doing field work in Mali. And somebody said to me along the way, why aren't you doing this in sickle? Because nobody's doing this, genetic association studies. So then the rest is history. That's where I really dove into sickle cell. And I guess I did a 3-year postdoc in genetics in a laboratory, but I also started attending at Johns Hopkins in pediatric hematology to really focus myself on sickle cell.
Excellent.
And Then when I finished fellowship, there was a guy at NIH who was trying to hire adult hematologists, and he couldn't find anybody.
Nope.
He had hired one pediatric hematologist who happened to be my attending in fellowship. So he hired me then, and I've never looked back. I've only seen adults throughout my career. I've never had an appointment in a pediatric department. So I'm in internal medicine at Howard, and I'm a pediatric hematologist oncologist. but I think the thing that emphasized to me, pediatrics and internal medicine are not that much different.
Yep.
And sickle cell is, you got to be a specialist in everything,
Yep.
cardiology, pulmonary,
Yep.
neurology. And so it's given me a lot of comfort in learning about what I don't know and becoming a specialist in that area.
Well, I mean, even things, that's the fascinating thing about this in training. When I started mine, it was the era of HIV.
Right.
Right. And before that, there wasn't much about immunology.
Right.
You had to know everything, CD4s, everything,
Right.
viral loads. That was not part of the picture. So now even with COVID-19, there's a whole new slew of things to learn.
That's right.
So
That's right. And even in HIV, the first people who were doing it were hematologists, oncologists, because they saw Kaposi sarcoma. And that in my training, I spent more time with pediatric HIV than most physicians.
Yeah.
And that's just a legacy of how the specialty evolved and who was seeing what.
Yeah. So, I mean, it's fascinating to see these things, that, it does impact who you become. The path that you follow is one that you have curiosity.
Well, as somebody said, I'm filling a need and I'm filling a niche because there aren't adult hematologists, oncologists, or enough of them to do this.
Yeah, yeah. And in particular, the history for sickle cell,
Right.
which we'll elaborate, in your role. Now, I'm also a graduate of Howard University College of Medicine. And I found it just a wealth of experiences that really kind of galvanized my approach to medicine and practice.
And I think being a faculty member there, I see that every day.
Yeah.
What we see at Howard impacts the students, and that's why they go into primary care areas and underserved areas.
Yeah, and we're not spoon-fed,
Right.
We take initiative. It's that was one of the mottos that we had, was that, just take it and run.
Well, that's the motto of the school,
Yeah.
serve the underserved. It's
Yep.
not an HBCU.
Yeah, yeah.
It's to serve the underserved,
Yeah.
and they mean it.
Yeah. No, that's true. That's true. So at Howard, what brought you to Howard specifically?
So I was at NIH for 18 years. Eventually, my big boss left, and I moved into a principal investigator position. And I had a protocol that was recruiting heavily out of Howard University. So my old boss described pulmonary hypertension and sickle cell. The first case was described, of course, at Howard in 1964.
Wow.
Dr. Gladwin's paper was published in 2004, but more than half the patients came from the Howard Clinic. And we continued that protocol. So I had recruited about 700 subjects onto that study with a biospecimen repository over 15 years, and I saw all 700 patients at 2-year intervals, and I really became an expert. And I kept on getting calls from my colleague at Howard saying, we have a director's position. We'd like you to apply. And I said, well, the timing's not right. But eventually he kept on calling, and the timing was right, and it just fell into place.
Yeah. What have been the challenges with sickle cell as a clinician?
So resources, whether it's at the NIH or at Howard University, at one point in my career, I've had a couple of pulmonary embolisms myself, and I had a second one at one point, and I called in sick to work, and I said, I got to go and see my doctor. And they said, oh, well, we have no clinical backup for you. And what I didn't realize were all the trainee, the fellows, were in clinic that day, and I had to supervise them, and they didn't have anybody to back me up. That is the story in sickle cell.
Yeah,
Resources and depth of people working in the field to cover when you're not there.
Yeah. And I know it's the clinical part, but it's also the social part, the impact it has on families.
So the social part is much more important.
Yeah.
So I know a family where a mother just passed away. She had sickle cell trait. Her passing had nothing to do with sickle cell, but her sister had sickle cell anemia. Her daughter has sickle cell anemia. Cousins in the family have sickle cell anemia. So this poor woman was surrounded by sickle cell, but its impact on the family, and this is something I'd share, My cousin is of mixed ancestry. His mother was my dad's sister, and his father was African American, really wasn't involved in his life, but his family is touched by sickle cell. So I've literally sat around the dinner table at Thanksgiving and talked with the mother of the patient. And what I heard was, my brother walls himself off and will not talk to us when he's in the hospital. It's like he's alone and has to deal with this alone. He won't utilize family psychosocial support. And I said, well, you have a family member who's a sickle cell expert. Here's my card. I can fly him across the country, get him evaluated for a bone marrow transplant, because I know he's got siblings who are sitting here who are potential matches, and never called. This is very common in sickle cell, and it's that was almost an aha moment at that Thanksgiving dinner, because I finally realized that the patients psychologically really wall themselves off. And I've seen this in other patients where spouses don't come in for married couples. And it's because the patient is trying to protect their spouse from the trauma that they're going through.
Yeah, and it is a horrific condition.
And it's a horrific condition, and horrific conditions require psychosocial support, which is psychiatrists, psychologists, but also family and social support. And these patients are rejecting it.
Yeah. And it's also culturally, it targets a population that then, sickle cell itself in the African American community. Certainly, if you compare that to other disease conditions and the amount of funding that goes into those, sickle cell, unfortunately, historically, has been...
I think I put my finger on why this happened. So this is the only disease in 1972. This is the 50th anniversary. May 16th, 1972, President Nixon signed Public Law 92-294 into law. That was the National Sickle Cell Control Act. But it took an act of Congress to force the NIH to start funding sickle cell research. But I finally understood why that was. Cystic fibrosis is a comparably devastating genetic disease that primarily affects people of Northern European ancestry. It's a lung disease. Premature mortality. So it's very comparable to sickle cell. That was described in 1938. Sickle cell was described in 1910. So why are we so far behind in sickle cell? It's because medicine was segregated.
Yes.
Until the 1960s, that's when things started to break. So my predecessor at Howard, Roland Scott, he had to apply the American Academy of Pediatrics 6 times after he passed his boards because he was black. And there was a resistance to accepting him. But so it was segregated for Dr. Scott. It was also segregated for patients. And that means that the only people who would have been seeing sickle cell often enough, people like me who have seen a couple thousand patients, would be people like Dr. Scott. And if they were applying for grants, well, he was black. So he wasn't going to get anything from the NIH because it wasn't a priority. This is the legacy of segregation in medicine. And that's the disparity. And that's why in 1972, that's where it kind of came to a head. But we can look at that very, very carefully. And the grant funding was not there. Who lobbied or testified against this piece of legislation the most? The NIH. Because they said that it duplicated their authority to fund grants. But they weren't funding the grants in the first place. So that's where this disparity came in, and it persists today. And even in that act, it took money away from other areas of NIH, cardiopulmonary disease, and heart, lung, and blood, and that nobody's ever forgotten that.
Legacies. And so, one of the interesting factors for that, for Howard specifically, it's in a sense a mecca for sickle cell, and where would other people go? Certainly, we've interacted with regards to my client, and my client, actually has intellectual disabilities. So the peculiarities of his condition, it's been challenging for both you and I. And the good thing is we've been able to collaborate well enough that we've seen a change. But the factors that are associated with it, are very, very complex, and there aren't the resources, there aren't the support. What do you think, what would you want to see change that may turn this around?
So I think when I was a fourth-year medical student, I had the opportunity to go back home to California and rotate at Stanford in pediatric genetics. And this is right around the time that the Marfan's gene was cloned on the East Coast, but there was a lab at Stanford that was very involved in it. They had twice a month Marfan's clinic. It's multidisciplinary. You had pediatric genetics, so I was there, cardiothoracic surgery, cardiology, dentistry, ENT, ophthalmology, social work, all in one clinic, one-stop shopping for all the, so the specialists came to the patients who have a multidisciplinary condition. And that's what I'd like to see with sickle cell. When I was at NIH with my former boss, Mark Gladwin, Dr. Gladwin was very talented at bringing more resources in. So we had cardiology and psychiatry and often pain management in the clinic. And we're all managing the patients, but if I had a pulmonary question, I'd go walk across the hall and talk to the pulmonologist, but I'd make the decisions and prescribe the medications. And when they had a sickle cell hematology question, they'd walk across the hall and ask me, but you don't have to be a specialist. And even with our mutual patient, there's a psychiatrist that we're working with from out of the region, 50 or so miles away. That psychiatrist knows how to manage sickle cell as well as I do. And we've seen it. And that's the nature of sickle cell. You have to see the whole person, whether your specialty is in the head or in the blood. You need to manage all of these factors because they all impact the disease.
And the social aspects of it.
And so I'd say we need the former Assistant Secretary of Health said, was introducing me at a talk once and said the biggest need are mental health needs in sickle cell. And I was like, wow, this is somebody I want to talk to.
No, absolutely.
Because for a politician to say something like that, that's pretty profound and incredible insight. So that's what we need. Psychiatry in the clinics with us, because we deal with, I once did a study, 20% of the patients in a clinical setting are depressed, clinically depressed. 10%
Chronic
are
pain.
Suicidal, have suicidal ideation. And it's from chronic pain and just despair around a devastating disease that is often misunderstood and undertreated, quite honestly.
And we've seen that directly when we talk about misunderstanding other clinicians who may want to do well, but particularly for our client, appearing in an emergency room, a busy emergency room, they only have so much time. They get partial records, and they, with a patient who is also intellectually challenged, even complicates it more. In trying to do the right thing, very often, unfortunately, they can't and don't, and it puts the patient at risk.
So the CMO of Jefferson Health said a few years ago, this was in the setting of Hahnemann University Hospital being closed. They weren't with Jefferson, but the CMO at Jefferson Health said, we're trying to implement 21st century therapy with a 19th century healthcare delivery system. And what I'd say about sickle cell is we have a 19th century research program and a 19th century healthcare delivery system, and we're trying to implement 21st century therapy for them, and it just doesn't work. And this is exactly what the ER physicians face. They don't have complete information. And they don't know that the patient may have been to 3 ERs that day. And had labs at all 3 ERs.
And that's our client.
And that's our client. And it's wasteful and potentially harmful to the patient. That's what disturbs me. So it's taken, in this one case, tremendous effort of 3 physicians working on one patient, hours and hours, and calling ERs and talking to them about the patient. And it's resulted in good care, but the number of hours that we've expended for one person, it's worth it. But it's not worth it in a financial business and medicine sense.
It's worth it in a sense because we knew that he was basically $1 million client every year for medical services that really weren't changing the outcomes.
Well, billed services were $1 million. Paid claims were 60% or more lower.
But the point of it is that the utilization wasn't changing the outcome. And every effort that we made it needs to be, in a sense, recognized that effort is leading to a better outcome, and without, overutilization of an already burdened healthcare system. Right. So at some point, you've got to say, and so that's what we've been working on too, is trying to reach out to the appropriate Medicaid specifically, about how to address this. Is it appreciated? It doesn't matter to me.
It doesn't matter to me. I care about the patient outcome and that they get good care. And I don't want them to get unnecessary or harmful care.
Exactly.
So that's what matters to me. The cost, I see a lot of cost savings in this particular case.
Yes.
But I care more about the patient outcome.
Yeah. And, well, we have a comparable. So in 2002, I actually lobbied with colleagues in Congress for the Independence at Home Act. That act was to do cost savings sharing with Medicare for providing house calls in the home. And there have been demonstration projects, and everything has gone through. 17% reduction in costs and better outcomes is billions of dollars.
Yeah.
And
so this is also in the era of the Sickle Cell Control Act. So that act only was funded for 3 years, and then sickle cell got tied into genetic diseases, which really lost the focus on the disease. And there was even talk about a sickle cell anemia institute. Hematology might be a more prominent specialty if there had been a sickle cell institute, but nonetheless, one of the things in the 70s that they were doing at Howard were home visits, assessing the home environment. And I have to say, the other thing that has come across my desk this year is the number of homeless patients that we have. And it's astronomical. Yeah. Why are they homeless? Well, it's the reason why they're on Medicaid. Yep. They're so sick, they can't work. If they can't work, they have no income. If they have no income and they don't have family that can subsidize them, they don't have any place to live. And putting somebody with such a terrible disease in a homeless shelter is a recipe for disaster. And this is something, without the funding of the sickle cell centers like they were in the 70s, 80s, and the 90s, without that, you can't do those types of home visits. And that provides tremendous insight into what's going on with the patient.
Yeah. And for our client, I actually went to the home.
Yeah, you did.
And saw it, and I was like, okay, this is very telling. There's a lot more going on.
Right.
And eventually, with enough effort from everyone, including the client, that we can actually turn it around.
So one of the things that has sort of come to my mind as you've been speaking about this is sort of HBCUs, and Howard specifically seems like a pioneer in this field. Has that been an inspiration for other institutions, research and academic, to kind of pick up the slack?
Yes and no. When the Sickle Cell Control Act was enacted, the NIH got 175 grant applications. They've been funding 24 a year prior to that time. So once the money was there, everyone became an expert. And Howard really was a pioneer institution. My predecessor, Dr. Scott, started his sickle cell research in the 40s and published his first paper in 1948. The trouble is, Howard never really got that much funding, but what have they described? The first newborn screening study in sickle cell, the first case of pulmonary hypertension. The NIH has now spent millions of dollars on pulmonary hypertension research. Where did it come from? Howard. Where did the patients come from in many of the studies? Howard. How much money has Howard received? Not enough. In the current era, we're studying complications of transfusion therapy that include iron overload, iron metabolism, a real problem in sickle cell, the development of antibodies to blood after blood transfusions that can limit the utilization of transfusion therapy in sickle cell and can lead to some very dangerous conditions. And then the last thing, my colleague is studying sickle cell disease and sickle cell trait and its ability to act as a resistance factor to HIV replication. So, and this is something that I'm intimately involved in. 20 years ago, we had a mutual patient between Howard and NIH who had HIV and sickle cell disease, and they were a slow progressor. And I've been around HIV in Africa and in the United States, and before antiretroviral therapy, especially heart therapy, people were dying rapidly. And this patient didn't take their meds, didn't take anything for sickle cell, didn't take their HIV meds, and still wasn't progressing. And when they died, it was not because of HIV. So that's kind of one thing that we pursued, and we actually have a molecular mechanism behind that, and we see things around the world where there's an interface there. So that's inspiring research, but what I'd say is with the HIV sickle cell interaction, there's been skepticism in the United States. We have a lot of connections with Africa in the research space, and so we go to meetings, the African Hematologic Society, the Nigerian Society of Hematology, and when my colleague presents this, he's like a rock star there because all the clinicians are sitting in the audience saying, yeah, that's right, we see this all the time. But again, it's because they're seeing thousands of patients with those conditions, and they see this and understand this clinically. So Howard's kind of a mixed bag. We'd like to have more NIH research funding. I think clinical care goes hand in hand with research. And if you know your patients and they trust you, they will almost always sign up for studies. Not that we coerce them, but they're like, yes, I trust you.
For the betterment.
If you're recommending something and are straightforward with me, I'll definitely do it. So I think that's the strength of the HBCUs, that we focus on the person holistically and have that intimate sense of trust, and that just makes research so much easier.
Yeah, that's fascinating. So in this part of your journey as a physician, serving in a wide area, but specifically sickle cell, there has to be a legacy. And this is always something I focus in on. Like, you get hit by a bus tomorrow.
Yeah.
What legacy? I mean, how are you passing it on?
So I've thought about this a lot. So one, I have to be very careful in this. Howard receives a federal appropriation, but the wonderful thing about going to Howard, I've been interacting with politicians from African countries. And I mean, like the leaders, going to presidential compounds. That's where you can influence policy overseas. At Howard, I've also been to the Senate and House office buildings to meet with policy advisors. I've met with a senior policy advisor at HHS about, and they're not asking me to define policy, but they're saying, what do you need? What should we do? What are good ideas? That's one legacy. And I think, one thing that I would say, we need a national health insurance program, and we need specialized, just for sickle cell, and we need specialized centers. So hemophilia, if you have that blood disease, you go to a hemophilia treatment center, and those patients generally don't go anywhere else. So they're seeing ultimate specialists, and that's what sickle cell needs. How do you do that without mandating it to people? You give more money to the sickle cell centers where the specialists are, 40% reimbursement instead of 33%. And then you give 20% to everyone else. And they'll be mailing the patients to us left and right, just from a but it'll result in better care for the patients. What is my other legacy? I think that Howard, what's the difference between Harvard and Howard? I don't know, $50 billion of endowment money. Howard, it's understandable. It's a population, even the undergrad, people who get their college degree or the MD degree, the legacy is they don't have wealthy alumni. So their take and their donations are lower on average. So I think in sickle cell, I want to build an endowment. I already have a 7-figure inaugural donor, and I've got a number in mind, and if I hit that number, we can run the whole center and subsidize all that we do. And unfortunately, that's a reality in sickle cell. It's not a money maker, so we've got to figure out another way to subsidize things. But that can subsidize salaries for people to provide care to patients, and subsidize research to provide us with preliminary data. And then you have a powerful grant application. You can go to the NIH and say, I have this great idea, but we're going to match you dollar for dollar from our endowment fund that we've built ourselves. So that's, I hope that legacy comes to fruition, and I think that would be a fitting honor to Dr. Scott, who founded the center.
Exactly. And
carry his legacy forward.
And that's the other part of this is, can you identify somebody who you're going to pass the baton to?
I hope so. I've been trying to hire physicians for 5 years now
Okay.
and have yet to be successful.
Okay.
It really is an underserved area. And I'm pulling out all the stops, calling people that I know personally saying, you're the person that I want. And they have another offer or something else.
Well, that's the challenge. I mean, maybe we do how, you actually developed your interest in medical school.
Yes.
So maybe we just hop over to the medical school.
I think this is something, so one thing that I'm hyper aware of at Howard, many of the Howard undergraduate biology majors or pre-meds go to other medical schools.
Yes.
I would like to keep more of them at Howard because some of the legacy of segregation in medicine, I think we should be teaching that in medical school. It wasn't taught to me.
Yeah.
But I think
Yeah,
that would be a unique curriculum at Howard. But I think that's my other initiative is to reach out to the medical school. I lecture to them first year, second year, third year, and I've got a fourth year rotation. And I'm going to go in now and start telling them that we need people. It's an underserved area. And when we tell them that, I'm sure some of them will respond and say there's a real niche here to treat patients.
And this is where you come up against the how medical education is now, where you're $250,000 in debt, so you have to do orthopedics or you have to do some specialty.
Yes.
I mean, being a pediatric hematologist at Howard is not a moneymaker.
No.
And paying off those student loans is on the minds of many medical students.
So I graduated, the day I graduated from medical school, my debt was $160,000. And in that era, that was a lot of money. I calculated out that I could defer 3 years of residency, and then I'd have to start paying. And if I got into my fellowship, I couldn't afford it.
Yes.
So what did I do? I went to the NIH program for a reason. I was one of the NIH loan repayment people. And I paid my loans off within 8 years of graduating medical school.
Wow.
It was a very generous program, but I called the right people, and that's something when we talk, we have a lot of doom and gloom in sickle cell, but I'm inspired by people who recognize ways to, it never ceases to amaze me, the imagination in human ingenuity. There's a way if there's a will. So an endowment is the obvious answer for sickle cell. That can also translate into other people, and they just need to think of creative ways to do this.
Yeah. I mean, we have other services like in primary care.
Yes.
There are funding to really promote primary care. Unfortunately, that's hasn't done much.
And so, another thought for the endowment fund, I want to fund an MD PhD student once every 4 or 5 years.
Yep.
That would be a physician scientist that we could recruit to Howard.
Yep.
For black physicians, especially black physician scientists, there aren't many of them, so that's something that we can do in a positive way. And if it fits my individual needs of recruiting somebody into sickle cell, that's terrific. If that person goes on to discover great things and define new therapies, even better. So it's something that we can create the opportunity for ourselves at Howard within the system. And when you look at businesses and organizations, hiring from within actually is a reasonable strategy. It has some limitations to it, but Washington University in St. Louis has a lot of inbreeding there. People stay there for their entire careers, and it's because they identify talented people and they want to keep them there.
Yeah.
And I think that's something that Howard can do.
Yes, I think so. And we also the president directly has an impact.
So the president of Howard University has sickle cell anemia. He's very open about it. That's one of the other advantages, and was a calculus in coming to Howard. Sickle cell is very important at Howard.
Yeah. Well, let's explore that opportunity.
Okay.
Get an opportunity to come to Howard and go back to my roots and explore the clinic environment.
Yeah.
But also maybe even hop over to the medical school and some of the fellows, residents. That would be I think that's important for people to kind of come on that journey with us to really dig in on this.
Yeah.
So, but thank you so much. This is fantastic.
Thank you.
Greatly appreciate you coming by. I know It's never easy getting around the city now that traffic is back.
The traffic is back
Yes,
in full
yes,
force,
yes.
and we're getting into the weekend here. So thanks again for tuning in with us. Dr. Jim Taylor over at Howard University. Hopefully we'll be able to follow up on this and actually go over to the university and film a little bit and do a field piece. So that is maybe the next step. So thanks for tuning in. We'll see everybody
Thank you.
later.
And if you happen to find any of this interesting, or more importantly, if you want to collaborate, check out the link below so that you can send us your comments, any stories you may have, anything. We're happy to entertain it. And this is really about us going on a journey together.